Hey guys, so we'll be discussing new topics today. Starting off with Ambu Bag. We'll talk about Ambu Bag in depth in pediatrics. Here we'll only cover the basics and the parts which are, you know, um, more of anesthesia related. So Ambu stands for Artificial Manual Breathing Unit. Okay, it consists of two inlets. Okay, one is the O2 inlet, the second one is the air inlet. Okay, the self-inflating rubber bag, a unidirectional valve which is called as the Rubens valve. Okay, so there are basically three valves, right? But what I want to stress on is that uh, Ambu bag should be covered properly in pediatrics. Okay, it won't make much of the sense if we discuss everything over here in anesthesia. So please do read it from pediatrics, or I'll discuss them in the coming lectures, hopefully. So the unidirectional valve, which is to prevent rebreathing. Okay, this is called as the Rubens valve. Okay, so how do we make a mnemonic? I think you all guys, if you guys are football fans, so you must be knowing Arden Robin. He only goes in one direction. He only knows how to move forward. So it's unidirectional. So it's called as the Rubens valve. Now maximum O2 delivered is 100%. Very important. The maximum O2 delivered is 100%. What are the sizes of ambu bags? If you're using them for neonate resuscitation, then the volume is around 240 ml. If you're using them in children, 500, almost twice the size and the volume of neonates. Adults, again twice the size, twice the volume of children amber bag. That is 1,000 to 1 liter to 2 liters. And then we've got the Venturi masks. We're comparing ambu bags with the Venturi masks. The Venturi masks, they deliver 60% of O2, whereas the ambu bag delivers around 100 ml, 100% of the O2. Okay, now coming on to the face mask. Now ambu bag is supplemented by face mask so as to breathe, right? So face mask is used to provide seal for the PPV, that is a positive pressure ventilation. Okay, so before doing any of these, I'd like you to study the you know the basics of neonate resuscitation. So you'll get a basic idea what a positive pressure ventilation is, when do we use it, when do we go for the ambu bag, and all those things, right? So it is made up of anti-static rubber. So it is made up of anti-static rubber. Sizes are variable. The drawbacks of using wrong sized face mask is that, first of all, proper seal isn't formed, okay, and ventilation is not done. So whatever you want, I mean, if you want to uh, give proper ventilation to the person, so because the seal is not proper, you won't be able to get appropriate ventilation. First is this thing, okay. Injury to the facial structure, especially eyes, if it is like a bigger one, if you're not using the proper face mask for the new unit per se, okay, in that case it might lead to injury to the eyes, okay, or to the facial structure. So basically we're talking about eyes because it is more common in case of infants. In small children, bigger masks, if there's a small children, if you're using a bigger mask, it will lead to increase in the dead space, okay. So the dead space is increased, so that is very important. Now coming on to the Goodle oropharyngeal airway. The Goodle oropharyngeal airway, it is used to prevent back fall of the tongue during anesthesia, okay. So this Goodle airway, okay, I think you guys must have seen the specimen, or you must have seen the instrument back in your fourth year. So it is used to prevent the backfall of tongue during anesthesia, right? Very important instrument. Various sizes are available. So correct size is determined by distance between the angle of mouth and tragus. So angle of mouth and tragus should be the size of a normal Google level for the person. Okay, so we have to calculate the size from the tragus to the angle of mouth, and that will be the appropriate size of the Google airway that we have to use. Now coming on to Suffer and Brooks airway. Suffer and Brooks airway. This is used for resuscitation by combining two Goodle airways. So we combine two Goodle airways, and that is called as Suffer and Brooks airways. So Suffer किसी के साथ होता है, and that includes two people, right? So that is a mnemonic, right? So two people, two good people, and two Goodle airways. Okay. Water airway, that means made up of metallic, while a rest are made of plastic. So this is the only difference. And this one is made up of metal. This is made up of metal, while rest of them are made up of plastic. This is called as water airway, right? Obviously, it's a bit different. I mean, like, it's very difficult and weird that a metal is made by water, right? But again, you have to remember that. So water and metal. Okay, when you invert the W, it becomes M. Okay, so that is the only mnemonic I could come up with. So water, that is W, when inverted, will give you M. So that is metal. So this is made up of metal. The rest are made up of plastic. Now, coming on to the laryngeal mask airway. Okay, so this is basically a supraglottic device, not definitive airway. Okay, so it is a supraglottic device. Okay, so Propof. So propofol is used for to suppress the airway reflexes. Right, we use propofol to suppress the airway reflexes. This is pretty important. Okay, so supraglottic device, we want to prevent any airway reflex. And what is the advantage of using this? First of all, it is easy to insert. Do not require laryngoscope or MRs. Right. Now, can be used for difficult intubation and CPR as well. Can be used for difficult intubation and CPR. Okay. So first of all, it is easy to insert. Do not require laryngoscope or MRs. Can be used for difficult intubation and CPR. Okay. Third thing is that there is less chance of bronchospasm. Okay. Do not cause the endobrachial intubation. So it does not cause any. Yeah, it does not cause any endobrachial. So what am I saying? It's endobronchial intubation. Does not cause any endobronchial intubation, right? And less chances of oral trauma. So these are the 5 advantages. First of all, easier to insert. Second is that it can be used for difficult intubation and CPR. Third is the less chances of bronchospasm. Fourth is do not cause any endobronchial intubation. Fifth is the less chances of oral trauma. And important point is that propofol is used to suppress the airway reflexes. Now, what are the drawbacks? Do not prevent aspiration of the gastric contents. So, aspiration of the gastric contents into the lungs cannot be prevented by this method, by using this airway. Right. So, laryngeal mask airway do not prevent the aspiration of gastric contents, and also it will cause gastric distension. It causes gastric distension, which is actually the most important point, that it can cause gastric distension. So we have to be very aware while using this laryngeal mask airway. Okay, the size of laryngeal mask airway depends on the weight of the patients. So how do we decide? Like, as I told you about the Goodle's airway, we decide the size of the Goodle's airway by measuring the distance between the angle of mouth and the tragus, right? Here it depends on weight of the patients, like size 1, 1.5, 2, 2.5, 3, 4, 5 and 6. Okay, if the weight of the patient is 1 to 5, that means mostly neonates and infants. So here the size is 1 to 1. The size is 1. Okay, so it's a very easy thing to remember. You just write down 1 to 5, 5, 10, 10, 20, 30, 40. So here one thing to note is that there's no 40 in between. So it's going to be when there's a transition from 30, when you have 20 to 30 over here, right? It'll be 20 to 30 is size 2.5. Okay, 30 to 50 is size 3. Okay, is size 3. So it will be not 30 to 40 but 30 to 50 weight, and then 50 to 70, then 70 to 100, and then more than 100. Okay, so that is, I think you can just take a screenshot or write it down, because it's a bit difficult to remember, right? So 1.5. So when we are transitioning from 30 to 50 or 50 to 70, then we won't increase the size by 0.5, we'll just increase the size by 1. I hope you're getting what I'm trying to say. 1, 1.5, 2, 2.5, 3, 4, 5 and 6. Okay, so in all we've got 6 sizes, and every size has got its specific volume. Like the size 1 and 1.5, the cuff volume is around 2 to 4. It's around 2 to 4 ml. Okay, size 2, 10 ml, size 2.5. I think you can read it from here. Important to notice that size 4, 5 and 6, they've got 30 ml in the cuff as a cuff volume. Okay, now what are the contraindications to LMA? Okay, first of all, as I said, it can lead to gastric distension. So patients who have full stomach, like pregnancy, okay, or the patient has got tracheoesophageal fistula, in these cases we have to go for something else. I mean, like, we can't go for LMA here, right? So patients with pregnancy and patients who have full stomach we can't use the laryngeal mask airways in these patients. Full stomach patients. Second is patients with low pulmonary compliance. Okay, so like a patient having morbid obesity, they have low pulmonary compliance. Okay, so in these patients we have to go for something else. LMA is contraindicated. So pharyngeal abscess, in case of pharyngeal abscess, or Ludwig's angina, right? In these cases also, that means people with oral pathologies, we can't go for LMAs, right? So these are the 3 contraindications. Now, what are the types of LMA, sorry. We have classical, flexometallic, and fast track. Okay, I'm really sorry. Okay, so the type of LMAs can be classical, flexometallic, and fast track, right? Classical, this one can kink. Flexometallic does not kink, right? There's no kinking scene, no bending over here. Okay, so this is pretty cool. And then we've got fast track LMAs, that means used for difficult intubation. Okay, the success rate is around 98%. So this is difficult intubation. Okay, the success rate is around 98%. So whenever you have a difficult intubation in case of any obstruction in the airway, so in these cases we have to use fast track. Okay, so during difficult intubation, we'll go for fast track. The maximum size of endotracheal tube that can be placed through fast track LMA. So we have to what basically is the use of LMA. I think you get the point. It's a laryngeal mask airway, right? So we can intubate through this thing as well, right? That is why we're using it, right? So the maximum size of endotracheal tube that can be passed through the fast track LMA. As I said, it is used for difficult intubation. You're not able to intubate normally. So what you do is you put an LMA over there and then you pass the endotracheal tube through it. Okay, so if you put the size, see the endotracheal tube that can be passed through this fast track LMA, 3, 4 and 5. 3 for the size 6. Okay, 4, 6 size 6 is not size 6 basically. Size 3 is 6 millimeters, size 4 is 6.5 mm, and size 5 is 7 mm. So we can put this size 3, 4, 5 endotracheal tube through the fast track LMAs. Okay, 3, 4 and 5. And we've talked about the different sizes of the LMAs also based on the weight. Okay, so that is also very important. Now Prosil LMA, that is used for controlled ventilation. Okay, so we've talked about the classical LMA, the flexometallic, fast track LMA, and then Prosil LMA, that means used for controlled ventilation. An ideal LMA, that is, what is this? I think coffin made of gel is what we call it. This is a coffin made of gel. I think we'll talk about the laryngoscopes in the next part.